Morning. I thank ETG and Anand and Mahesh to inviting me. The topic is delayed cord clamping. Everybody is going to clamp the cord. It's right to delay the baby. It's a timing which is important, whether it's soon or delayed, and what is the advantage of it. Whether it's if we give delayed, there are must be certain advantage of it, and we have a very good speaker to speak on that, and he's going to clear our all the thoughts. Is none other than Dr. Pradeep Suryavanshi. He's a fellow of neonatal and parental medicine from Australia. He's the head of and professor at Bharati Vidyapit Medical College, Pune, and he's the first person to commence neonatal functional echocardiography in point of care and neonatal sonography, which has immensely changed the management of neonatal care in India. I invite Dr. Pradeep Suryavanshi to give his talk.
First of all, thanks to the Thane team. I've been really fortunate to Thane team. This is my 4th visit to Thane, and special thanks to the Bedekar team. I'm very fond of their family, and I'm a great follower of the Bedekar's father, and I listen a lot of time his father, and I must say openly that the vision what they are doing, not like that, but fantastic work what they are doing for country, and we all have to do something for our country. And that's the one thought this Perinatology meet we're trying to implement in Indian setups, that we should have more collaborations with our obstetric team. At an individual level, every obstetrician is doing great job. Every neonatologist is trying to save the newborn baby, but we want more. We want more. India needs more, and that's the reason why we started at state level about this Perinatology concept. And collaboration, more discussion between the obstetric teams and more discussion between the neonatal team. That is our thought about starting this one. The same background in this national state conference, the Paramanand and his team is taking in Mahapedicon. We have given one session for Perinatology. And I'm very thankful for the Thane team that they allowed to conduct this Perinatology team here about this session. Now, the answer is already very easy. The thoughts are easy. You all are doing a lot of things. So how many of you are actually doing the early clamping and delayed clamping? Just a few thought process from the audience. How many of you are clamping the cord early? But again, I'll come, you will say, ask the definition and all that thing. But you already know the answers. But anybody is doing the delayed cord clamping after 1 minute? After 1 minute. Okay, fantastic. Can I this one down? Is there any way that, okay, fine. All right, so sir is saying that sir is doing the milking of the cord, and 4 or 5 people, I saw the hands, they are doing the delayed cord clamping. Let's see that. That's what the question, and we'll work on that one. We'll try to see in the next 5 minutes about some physiology, which will help us to go ahead with these questions answer. At the same time, the current impact of the evidence-based medicine about these delayed cord clamping. I'm pretty sure that everybody has seen the animal delivery. More hands? How many of you have seen the animal deliveries? I know we all are obstetrician, but this is fantastic, I know. Okay. We have seen, and that's where, anybody has seen their obstetrician and pediatrician? Fantastic. We all are the mammals. Does they clamp the cord there? What happens to that? No, that's I'm happy. My voice is okay, I think. The voice is audible. Last people? Thank you. So this is where I think the thinking has changed in the last 10 years. And the physiology came into the picture about mammals and deliveries and the clamping and the hemodynamics. We'll discuss this one as the basic transition. I think we all know the transitional aspect from the fetal to neonatal life. We also know that in the world, when some human comes and he clamps, then and then baby and mother are getting separated currently. We also know that this clamping and the cutting of the cord has some time and everybody has some variable times. Somebody says that immediate, somebody says 15 seconds, somebody says 30 seconds, somebody says 1 minute. We'll come to some conclusion today in the discussion of next 20 minutes. If you see the history, it is like the Prithvi. आम्ही म्हणतो नेहमी पृथ्वी गोल आहे. Actually, we started a delayed cord clamping in the world. Then it gone to the early clamping or instant clamping, and now we are going back to delayed cord clamping. The basic definitions about the various authorities in the world, what we say that if we clamp the cord in the first 15 seconds, I think that is called as early clamping. And if we clamp after 1 minute, preferably up to 3 minutes, and some people say that if you wait till the pulse says stop, that would say that delayed cord clamping. So remember that at least 1 minute, that is what is the cutoff currently about delayed. But we'll come to that point once we found out some evidence. So let's review about the current evidence about the delayed cord clamping in the term babies. Here, as a Thane is quite ahead in the obstetric team. Most of the time, I think, if you see the consensus, the Thane district has monthly around 5,000 deliveries, I suppose, or more than that, the senior team members. So 5,000 deliveries, we are expecting about that 5,000, almost 4,500 as a term babies. We'll work on that one, and let's see that. What is the meaning of this transfusion? We call as a placental transfusion. We call as an auto transfusion or the ready-made transfusion to the newborn baby. The blood which is in the placenta, because somebody comes and clamps early, that blood is actually remained in the placenta, or we are not utilizing that blood. Imagine, what is that blood? Actually that blood belongs to the baby. That blood from mother to placenta to the baby, if we allow, the baby gets additional 80 to 100 ml of blood. If you see the normal physiology, a 3 kg normal weight baby, around 250 ml of blood, 85 ml per kg. 85 ml per kg is the blood amount available in the newborn baby. So roughly I would say around 250 ml of blood available in 3 kg baby. If we allow that placental transfusion, I am getting around 80 to 100 ml of blood additional. Can you imagine? The baby getting the first auto transfusion after the birth. You will say, why we need this auto transfusion? The babies are doing great without that also. Let's see the evidence. This is the picture you all have seen, and you are doing daily, day-to-day basis. We have marker here or the pointer. If we see the first one, the placenta at 0 minute, the placenta at the 3 minutes, and the baby at the 3 minutes. Can you see? That's the placenta, and that's the baby. It's immediately, that's the pale baby, or the placenta becomes the pale and baby becomes the pink. Naturally, when the placenta becomes the pale and the baby becomes the pink, you get additional around 80 to 100 ml of blood. And somebody says me that I don't have to check any blood. I am getting additional blood at the time of the birth, which is around 20 to 25 ml per kg, roughly, to the newborn baby. We are the first person to accept this concept. Why? We'll come to that point. So what we learned so far, we are getting more blood. By 3 minutes, at least 1 minute, yes. By getting more blood, if you see that naturally the blood volume is better, the red cell volume is better. If you see the hemoglobin, that is better at the time of the birth, at the time of 1 month, and at the time of 18 months. Those babies with the delayed cord clamping, they have less iron deficiency anemia. And that is the most important aspect on the earth. As you all know, almost 90% of the ladies coming to your unit might be iron deficiency anemia, or 70%. Similarly, in the pediatric practice, almost 60 to 70% of the infant have iron deficiency anemia. And we don't have to tell each other about the problems of iron deficiency anemia to us as a woman and to the baby in the Indian scenario. The biggest problem for us in infancy is the nutritional problems. And the nutritional problem is a physiological exaggerated iron deficiency anemia. By delayed cord clamping, you are actually preventing the iron deficiency anemia. So somebody gives me the gift. So I request the gift from obstetrician all the time. Delayed cord clamping, ultimately less iron deficiency anemia. Better neurodevelopmental outcome into the infant. Better brain growth into the infant. Fantastic. We don't have to do anything. It is automatic. It is auto transfusion. The blood is there. We should allow that blood. And that's the concept about the delayed cord clamping in the term babies. Naturally, a lot of studies, but the best study also comes from India. And we allow the iron stores increase by 3 months. The iron stores were very high. The ferritin levels were very high. Less iron deficiency anemia in those babies who have a delayed cord clamping. I'm talking term babies. What about the meta-analysis? Of course, the meta-analysis also shows that these are the babies who have a better iron, better ferritin, better hemoglobin, better blood volume, and they have a better neurodevelopmental outcome at 18 to 24 months. So when we talk about the neurodevelopmental outcome, when we talk about the brain, this is the one intervention which has changed the transitional period. And that's what we are talking here. What about the Cochrane? The Cochrane definitely says that you should allow at least 60 seconds, more than 1 minute. Fantastic. Around 3,000 babies at that time, and they also showed that the better ferritin level, they have shown that they have better hemoglobin level at 3 months. They have also shown that fantastic lot of advantages. So the first thing what we are going to concern that delayed cord clamping in term babies, better hematocrit, better hemoglobin at 2 days, definitely less anemia, slightly higher polycythemia, but not significant. But slightly high polycythemia might be chance in IUGR babies, accepted. Once there is slightly high polycythemia, little bit high incidence of jaundice, accepted. Because the treatment of jaundice has become so easy. Most of the obstetricians, they have the phototherapy now. So not issue, we can accept that. So there is not much one, better ferritin level, better iron level, less anemia, and better neurodevelopment outcome. So if you remember this slide, I'm very happy. Once we say that the iron levels are better, less iron deficiency anemia, and better neurodevelopment outcome, you all will definitely doing this delayed cord clamping. That I'm sure. What about preterms? We say that we are dealing with more high-risk settings. We say that we are metropolitan. We get a lot of preterm babies. Let's see about preterms and delayed cord clamping. This is the one famous study that, this study has shown that the delayed cord clamping improves the cerebral oxygenation, improves the cerebral blood flow, improves the supravena cava blood flow, and by that, it decreases the intraventricular hemorrhage, and it decreases the NEC, decreases the sepsis. Now, you don't have to become neonatologist to understand this terminology. We as a practitioner, the first question obstetrician asks us within first 72 hours, brain बरा आहे ना? ब्लीड झालेलं नाही ना? आपण पुढे जाऊ देऊ ना त्या 25 वीकरला, 26 वीकरला? Because all you know that if you have massive bleed or if you have a sepsis, if you have NEC, outcomes are bad. So, because of the delayed cord clamping, we say that this is going to be advantage because of the better oxygenation, better blood flow, less IVH. Why not to accept? So somebody is saying that the IVH is going to be less. By this one, we are so happy. That's what I just told about the blood flow mechanism. And this was the famous study about the cerebral oxygenation, that it improves the cerebral oxygenation, it improves the blood flow, and by doing that, mainly improving the SVC flow, that's what we measure. Naturally, the Cochrane also supports in the preterm babies about the delayed cord clamping and plenty of advantages. Naturally, the oxygen is better, hemoglobin is better, the volume is better. Just now I told you about minimum 10 to 25 ml per kg. For preterm 1 kg, I told you 85 ml. So 85 ml plus this 15 ml, 100 ml. Can you imagine the preterm who is suppose 28 weeker? 28 weeker 1 kg, the volume is 85 ml, and by this delayed cord clamping, we have additional 15 ml, I have 100 ml of blood. Because the doctors, the neonatologists, they are called as the blood sucking doctors. We lot of daily we take bloods. I hope Anand is not taking too much blood. So we take a lot of bloods, and by the end of the 15 days, we have to give one transfusion. There is not a single preterm currently, I believe, that less than 26 weeker who is not going home without transfusion. If we say that these babies already getting transfusion of this 15 ml, we are so happy. No cross match, no collection of the blood is ready, which belongs to the baby. Please allow that. Naturally, the blood pressure is better in the preterm babies. IVH is less, NEC is less, sepsis is less. That's the Cochrane says. That's what all these Cochrane studies. No difference on the Apgar scores, no maternal problems, and there is less death, because people are worried about does mother has a problems, does there are issues with this delayed cord clamping associated with this one. So if we see that term babies, fantastic, because less iron deficiency. I told slightly more jaundice, but I think you all will be happy to give the phototherapy. At least pediatricians will be happy. At least the Parmanand will say that I will get a baby with a 3 days NICU stay. Just joking. The preterm baby, naturally, we are saying that more blood volume, less problems of the hypotension, less requirements of inotrope, less IVH, less sepsis, less NAC. Do we need to become neonatologist? You will send less baby to the Anand. Naturally, the baby's outcome will be better. Survival will be better. And neurodevelopment outcome will be better. And that's what we are saying, delayed cord clamping. What about the various societies are saying that? These are the circulation guidelines published in the October 2015, and we say that the preterm babies also, we should allow delayed cord clamping. You will say, oh, preterm requires resuscitation first. But if you see, 95% of the babies, they cry by own. 99% respond by simple bag and mass. Only 1% really requires extensive resuscitation. Only 1%. And that's the reason this is a fantastic way that even in very preterms, I'm talking very preterms, less than 28 weeker I'm talking. Naturally, we are thinking about the hypothermia, but at the same time, we should think about the delayed cord clamping at least 60 seconds. If you say that you are needing resuscitation, you can think about milking. Term baby is out of question. So this is where I would request all of you think about preterms also, about delayed cord clamping. What about the ACOG says that clamping the cord should be delayed for at least 60 seconds with the infant maintained at or below. This has gone after this is 2012, 2014 fantastic paper published in Lancet, and that says that you can keep the baby above or below, doesn't matter. You can allow the blood will come out anyway, doesn't matter about the below. It has associated the benefits, increased volume, reduced transfusion, decreased IVH, and lower iron deficiency anemia. That's 2012 ACOG. What about RCOG? This is RCOG 2015. The RCOG says that definitely healthy babies, evidence supports the cord clamping, decreases the iron deficiency. Preterm babies supports the evidence. Timing of the clamping should be routinely recorded in medical notes. Can you say that? We are noting Apgar score. Additional things, we have extended Apgar scores. And we are recommending now timing of the clamping should be recorded. Very, very important. Today, if you start this one, it will be helpful for all of you. Cord milking is alternative when the baby is very, very preterm. What about WHO? This is WHO in 2015. Delayed cord clamping, at least 1 minute, improve maternal and health benefits to all babies. So if you remember this chart, I'm more happy. Whatever 20 minutes, you are not listen or listen, but you remember these many advantages. Full advantages. There is no disadvantages. And that's the beauty of this mechanism. Because the blood is there, you don't have to do anything. Just you have to allow and wait for that clamping. That's the only thing you have to do. That's what is the requirement. And the last and most, what about the Professor Darwin has showed? This is in 1801. Please see this one. Another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breath, but till all the pulsation in the cord ceases, as otherwise child is much weaker than it ought to be, a portion of the blood being left in the placenta which ought to have been the child. That's in 1801. म्हणून म्हटलं पृथ्वी गोल आहे. So please and please follow simple things. This is going to have a big impact about survival, about the outcomes. We are not thinking today only the survivals. We are thinking intact survival. We are thinking how is the baby at 2 years, how is the baby at 5 years, how is the baby at 10 years. That is what we are thinking. As obstetrician, your role is definitely, that's we give the baby, you give the baby to us and you say, तुम्हाला जे वाटेल ते करा पण चांगलं करा. But what is चांगलं? It's intact survival. That's what our aim is. And that's one more mechanism we request that please do the delayed cord clamping. So dear friends, the placental transfusion occurs in all mammals except when another human clamps the cord early. The term baby delayed cord clamping increases the hemoglobin level, blood volume and iron stores. The preterm baby delayed cord clamping associated with increased blood volume, reduced need of blood transfusion, decreased incidence of intracranial hemorrhage and sepsis in preterm babies. The evidence supports the clinical benefit of delayed cord clamping in term as well as the preterm. Thank you.